Good afternoon, ladies and gentlemen, and welcome to the 2018 Joseph J. Kinyoun Memorial Lecture. Since 1979, NIAID has hosted this lecture series in honor of Dr. Joseph Kinyoun, pioneer of modern biomedical research. Dr. Kinyoun established a single-room laboratory of hygiene in 1887 on Staten Island in New York, which launched a new era of fighting infectious diseases through rigorous scientific research. In 1891, that laboratory moved to Washington, D.C., where it became the forerunner of what we now know as the 27 institutes and centers of the National Institutes of Health. His vision of bench-to-bedside care continues to inspire the NIH approach to developing new strategies to prevent, treat, and cure diseases and improve human health, not only in America, but throughout the world. Have the next slide, please. Our speaker today, Dr. Robert Redfield, is a longtime personal friend and close and respected professional colleague. Bob has spent more than 3 decades as a leader in public health and as a dedicated clinician scientist focused on human virology. Bob currently, as you know, is the director of the Centers for Disease Control and Prevention and administrator of the Agency for Toxic Substances and Disease Registry. Bob received his medical degree in 1977 from Georgetown University, after which he completed a residency and a fellowship in tropical medicine at the Walter Reed Army Medical Center. At Walter Reed, he served more than 20 years in the United States Army Medical Corps, retiring as a colonel in 1996. While completing his military service, he led some of the earliest clinical research on a disease that would ultimately be known as AIDS, and was the founding director of the Department of Retroviral Research within the United States Military HIV Research Program. After retiring from the military, Bob continued his pioneering HIV research and clinical care by co-founding the Institute of Human Virology at the University of Maryland with our former NCI colleagues, Drs. William Blattner and Bob Gallo. Bob also previously served as the Chief of Infectious Diseases and the Vice Chair of Medicine at the University of Maryland School of Medicine. In these roles, he has made many critical discoveries about HIV, and his research helped underscore the importance of heterosexual transmission in the global spread of HIV, and he helped elucidate the various stages of the HIV replication cycle, basic research that contributed to the discovery of effective antiretroviral therapy for HIV infection. As a physician scientist, he achieved all of this while treating more than 5,000 people living with HIV in the Washington and Baltimore areas. Since his March 2018 appointment to serve as the director of CDC, Bob has prioritized the federal response to the opioid epidemic, a public health emergency with devastating and far-reaching impact. According to 2016 CDC figures, 48.5 million Americans used illicit drugs or misused prescription drugs in the past year, and more than 197,000 people have died of opioid-related overdoses since 1999. Because opioids are sometimes injected with shared or reused needles, people with opioid use disorders are also susceptible to viral hepatitis, endocarditis, HIV, and other infectious harms. Bob is going to be telling us about all of this and these consequences of the opioid epidemic today. So please join me in welcoming Dr. Robert Redfield.
Thank you very much. It's really great to be here and be able to give an opportunity to talk about the interrelationship between the opioids and infectious diseases. I wanted to start, and Tony's already given you a background, but when you get an opportunity to have the honor to give a name lecture, I took the time to go back and read about Dr. Kinyoun. Obviously, and I think he saw very early the opportunity to put science into clinical medicine. And I think maybe many of you don't know that actually his first child, actually Betty, ended up dying of diphtheria. And some of the early discussions that he had after he had seen some of the early work of using antitoxin, was really to ask that question, was it possible? Was it possible to be able to bring this antitoxin in a meaningful way into clinical medicine to improve the human condition? For me, it's a real honor to come here because, as I told Tony, I spent a lot of my young days here at NIH in Building 10. My father was on the 7th floor in Building 10. He was studying, trying to understand the genetic code. Other people in that group, Marshall Neuenberg, Christian Affinson. Unfortunately, my father died in 1956 here while he was working at NIH. Subsequently, my mother, who was trained at her master's in biochemistry, decided to come to work also in Building 10, where she worked with Sidney Udenfriend and Herb Weisbach all the way up through 1969 when they went off to form the Institute of Molecular Biology up at Hoffman the Roche. Obviously, Mom, now being single after school, I would make my way down Old Georgetown Road to NIH, and you used to have, maybe you still do have, an old library that was in the back of Building 10, and that's where I would do my studies till we went home together. Occasionally, I would sneak up to the 13th floor and play some basketball. You had a basketball court up there. So it's really great. This is the first time I've really been back, in a meaningful way, but I wanted to share that I have a great love for NIH, as did my mom and dad. I thought I'd focus originally about the opioid epidemic, and I think it's important, Tony already alluded to, that the administration sees this as an extremely serious national public health issue. Recently, both at the president's level and also the secretary, it's one of his 4 pillars to begin to develop an effective response to the opioid epidemic, and we're going to talk a little bit more about it now. I think first and foremost, I just want to highlight what Tony said, that I do believe truthfully this is the public health crisis of our time. And it's not just a professional issue for me. Just like the name lecture, I almost lost one of my 6 children from cocaine that was cut with fentanyl. And had it not been for our emergency response team, I probably wouldn't have my son. So I've seen the impact of addiction first and foremost. I thought I understood it, having practiced in Baltimore for 22 years and had many patients that were heroin dependent. But I will tell you, I had no concept of the impact of addiction, particularly to cocaine or to opioids, until it really came into my own family. Some of you know me pretty well here in the room. We have a very strong family, but I can tell you it almost ripped our family apart as we tried to fight to get our son the care and treatment for him to confront his use of cocaine. I want to stress that what I want to stress and remind everybody that it's a medical condition. All too often, I think people think it's a moral failing. My own son was embarrassed to tell his mom and dad that he was using cocaine significantly. He felt that this was something he should be ashamed of. Rather than recognize he became progressively addicted and that really what he needed to do is to get the treatment and care that he needed. So I want to start with that. Many of you in the room may have family members that have struggled with addiction. And I will tell you what I've said publicly. I think we need to work together to support families that are confronting addiction and help them hope for success, because treatment success should be the rule, not the exception. And I will say that my son's in his 3rd year of recovery, and I thank God every day. I also say that stigma is something that we learned the hard way in the early AIDS epidemic. Stigma really is the enemy of public health. There's many lessons that we can glean from what we've learned over the years in dealing with the AIDS epidemic, and we may come back and talk about that later. But the one I think that's the most important is to understand the negative consequences of stigma. And if you think HIV had stigma, it's nothing compared to the stigma that we have among people that have drug addiction. Even the word addict is such a demoralizing, stigmatized term. People who get to hear me talk know I don't talk about the opioid disorder. I don't like the word disorder. It sounds so stigmatizing. It's a medical condition. Even the way we try to treat patients, with addiction. All too often in medical communities, we put them off into psychiatry if they want to get treated. And again, I'm not negative. Psychiatrists are great treaters for addiction and addiction medicine, but sometimes normalizing our approach to addiction medicine, so we integrate it into the diabetes clinic, the hypertension clinic, or as we did, the HIV clinic, is so important to make sure that we do our part to destigmatize this disease, because the stigma associated not just with the initial condition, but the stigma that comes with relapse. I kind of remember the analogy when someone has cancer and they're fortunate enough to go into remission. If they relapse and with recurrent disease, we don't really dump on them because they had a relapse of their disease. But someone with addiction, my own children tried to tell me that I had to get ready for a lifetime of relapse with my son and just accept it because treatment success was such a rare reality. The reality is treatment success in quality programs really needs to be the rule, and in many programs it now is the rule. And we need to support people who relapse so they can then recover again for an additional bout of treatment success. So the opioid epidemic, as mentioned, has really basically been a highly huge epidemic. As you can see, as we look at this now, since 2000, 600,000 people have died from overdose. You see that it's not just opioids. Last year, we lost 72,000 people from drug overdose, 48,000 from opioids. There's still a number of individuals that are dying as a consequence of drug overdose from amphetamines and cocaine, like the case was with my own son. These amphetamines and cocaine are all being contaminated with synthetic opioids, fentanyl being the worst, and has really caused a huge increase in death. And you can see there's been a series of waves of the epidemic, as you can see over time. Originally prescription opioids, and I think the medical community has to be honest about taking some responsibility for this. The Surgeon General and I are debating to write a perspectives on the death of the fifth vital sign, because I do think when we pushed pain control to the degree that we did, where reimbursement was linked to pain scores, I do think we've contributed to potentially the over-prescribing of opioids at some point in time. Heroin obviously became an expanding epidemic, and then finally now these synthetic opioids, which are really most likely going to get more and more potent as we have new derivatives of fentanyl hitting the market. And this just doesn't overlap, just to sort of show you what's happened to the epidemic in terms of drug overdose deaths from 2000 to 2005 to 2010 to 2016. You can see it's really throughout the United States, we continue to see increases in drug overdose related deaths. And when you look at it in terms of the rate per 100,000 for adults, or if you look at for drug use, for opioid use, or overdose deaths, you can really see, I mean, one of the hardest hit areas to talk about, obviously, is West Virginia, Kentucky, Tennessee. Well, you'll see some of the data that now 5% of all babies born in West Virginia are born with neonatal abstinence syndrome, and 14% of all women delivering birth have an opioid use condition. And this just looks about prescribing practices across the United States. This was shocking to me because, many of you know I come from an infectious disease background, so this has been, as the CDC director, as I've become more and more embedded in trying to confront this opioid epidemic. It was shocking to me where you see some of these areas where there's over 100 prescriptions per 100 people. I mean, it's remarkable the amount of narcotics that are prescribed in the United States today. And CDC, we have, and as I said, this is an overall administration perspective, and different aspects of different departments have different roles. HHS has an important role. The Secretary has made it one of his 4 pillars. Obviously, NIH has a critical role in that, not just in new discovery, which we're all waiting and hoping for in terms of developing the science that allows us to make this a highly treatable and hopefully curable disease. But obviously, you're very involved in helping operationalize some of the comprehensive community approaches to see if we can impact CDC has really looked at several things. We're working on trying to understand where the outbreak is, and one of the most important tools we've developed is the syndromic surveillance. I think one of the transitions that are occurring in public health right now is no longer is it a traditional public health approach where we have a doctor or a nurse practitioner make a diagnosis, call a health department, and basically report something, and then that gets reported up to the state. And then we begin to see data that may be a year or two old. But now actually the medical records themselves become the surveillance tool so that we can actually begin to see in real time through electronic medical records. When I became CDC director, one of the first areas that I asked to be briefed on was the opioid epidemic. And it was in early April, and they presented me data. And at the end, I asked what the data was up through, and they said March 2015. And I said, you know, I'm a CDC director, but I didn't know I was becoming a medical historian. I really wanted to see data more in real time. I'm really proud to say today, because of this investment, we're now with syndromic surveillance, the states are getting real-time data within 48 hours throughout the United States. Very powerful tool. It's going to go way beyond opioids. We'll be able to use it for other disease surveillance systems, including HIV, hepatitis, flu, et cetera, new syndromes that we're still trying to figure out. Prescriptive drug monitoring program, chronic disease and acute management, and outreach to the public, and I'll make a few comments on that. I mentioned the syndromic surveillance already. We really have, within a short time, within 6 months, changed the kinetics of it so that we can really see where the drug overdoses and drug overdose deaths are in real time, which is really important in trying to respond to this outbreak. Second thing is this prescription drug monitoring program. I mentioned that, you know, in some areas there's over 100 prescriptions per 100 people. This now is we have the ability to monitor prescriptions in all but one of the states. In the state of Missouri, it's not statewide, but about 85% of the jurisdictions report through St. Louis. All the other states have now statewide reporting of prescriptions so that you can find in real time whether someone has multiple prescriptions for those narcotics. And now those prescription monitoring programs actually go across state lines in 44 of the states across the United States, soon to be 49, so that you can basically see if there's potentially prescription misuse and begin to try to make an impact. And you can see that already we've seen some reduction. In Ohio, 85% reduction, Kentucky, 62% reduction, Florida, basically 80% reduction in prescriptions that are being filled for opioids. So beginning to see substantial. In terms of multiple prescribers for the same patients, we've seen a reduction in New York by 75%, in Tennessee by 36%. So again, trying to make an impact. The other thing that CDC has tried to do is develop guidelines to help physicians understand the appropriate use of opioids. First and foremost was to recognize that about 1 to 3 million people in America have a chronic dependency for managing their pain of opioids, and how to help maintain that. No one's trying to take that away, but how to maintain that, but to help manage that in the most effective and efficient way as we wait for alternatives that may have different consequences from the opioids. The second is acute pain guidelines, which we're working on now in terms of trying to come up with some guidance that will be coming out soon, and procedure and disease-specific guidance for, you know, say, for example, for a wisdom tooth extraction, or for a post-cholecystectomy, or for a broken arm. So there can be pretty much guidelines into what's appropriate. I can tell you I was shocked when I got educated as CDC director by my subject matter experts. Do you know what the probability of becoming a chronically dependent on an opioid is after a single prescription for something like a wisdom tooth? If your 16 or 18-year-old child had a wisdom tooth and was given opioids, or if you happened to break an arm and had opioids or got short-term opioids, I was shocked to see that 2 to 6% of individuals who have a single prescription for opioids become chronically dependent. So clearly trying to understand what the appropriate use of this medication is. I would say it's probably one of the most serious medical decisions we make when we prescribe opioids to a patient. Who knows whether my son was related when he was 16 and had his 4 wisdom teeth out and got opioids, whether that put him on the beginning of a path one way or the other, I don't know. But I do think that we probably don't have an understanding to the degree we should about the long-term medical consequences of that acute pain decision. And finally, obviously, trying to educate the American public that there are consequences to opioids and to try to work to find alternatives for their pain control. I mentioned that some of the states have had more difficulty than others, and West Virginia, which is really in our own backyard here, is one of the states that has had one of the most significant consequences from the opioid epidemic. I've got the opportunity to visit a number of times since I've been CDC director. I encourage any of you that are really into this to take time to go visit Huntington, West Virginia. This is a town that everyone in that town has been hit in the stomach from the consequences of this opioid epidemic, including family members that have died. And yet this town now has come back to put together what I believe is one of the most comprehensive community-wide, city-wide responses to challenge this opioid epidemic. And it's quite inspiring, and we can talk more about it if people want to learn more during questions. I mentioned in West Virginia, we're looking at 5% of all babies that are born now in that whole state are actually born dependent on opioids, and 14% of the mothers. One of the reasons this happened, and this goes back to why the prescriptive drug monitoring program is so important, that this one pharmacy, okay, where there was only less than 3,000 people, basically distributed almost 21 million pain pills in 1 year. Again, it was one of the biggest pill mills in the coast where people from many, many states came to that pharmacy. You kind of wonder how that happened. I mean, how could one pharmacy in one little town that only has 3,000 people somehow have a delivery of almost 21 million narcotic pills and no one seemed to notice? It does show you that there was, I think, a problem that has really been addressed now by the prescriptive drug monitoring program that we have in place. And as I mentioned, the West Virginia group has really begun to respond in a way that is quite inspiring to what they've been able to begin to put to place by allowing now individuals who, when they come to an emergency room, and it's true in many emergency rooms still in this country, if you come to an emergency room and you have a drug overdose and you get Narcan and you get better, you get discharged with a piece of paper to go follow up with someone that you may or may not be able to get an appointment with. If we came in with accelerated angina and the hospital discharged us without assuring us to make sure we got evaluated properly, that wouldn't be considered consistent with our profession. And yet with opioid, it really is. Now in West Virginia, you come in with a drug overdose and you're able to be recovered. That right then, you get to go into care and your family gets involved in care, and they bring you right into comprehensive care for your addiction if you want to. We need to see more of that example. And finally, if you look at the opioids, you can see that it does appear, and again, it's too early to say, it does appear that we're beginning to make an impact as a society. This is something I want to come back to about what we learned from the AIDS epidemic when we were much younger, both Dr. Fauci and I, Dr. Tremont here. Many of us saw the AIDS epidemic as a pretty big challenge. We didn't really see a path to success. We hadn't really had that much successful therapy for viral diseases. People were dying in the primes of their lives. I think a lot of people were wondering, would science actually solve the problem? Well, the reality is much of the science done here at NIH, as we look back now 30 years, has really allowed science to be applied in a way that HIV is a highly treatable disease where you can live a natural lifetime. I try to tell people that I'm confident that science will do the same for addiction. And it's not just opioid addiction. It could be amphetamine addiction. It can be cocaine addiction. It can be alcohol addiction. It can be nicotine addiction. The science that I think will come to be able to find the common path to treat addiction will also be as revolutionary as the science that came to make HIV and hepatitis C and hepatitis B treatable diseases. I wanted to shift gears now, as Tony, when we talked about maybe bringing this into the relationship between opioids and infectious diseases. Because the truth is the opioid epidemic can really have a pretty negative impact on the progress that we've made in confronting certain infectious diseases. And I think confronting the opioid epidemic successfully and being able to predict and negate the ability of the drug overdose epidemic in general to negatively impact infectious disease is important. Many of you probably remember the Scott County example in southern Indiana, where very rapidly, due to basically a group of individuals that were involved in intravenous drug abuse, very rapidly 233 people developed HIV infection, 90% co-infection with hepatitis C. It turned out that 5% of the population in this rural area became HIV infected, all as a consequence of the interrelationship between drug use and the ability to transmit HIV and hepatitis C, obviously causing a huge economic burden on that community, and showing the interrelationship to how the drug use epidemic can basically have significant impact when it comes to transmitting infectious diseases such like HIV and hepatitis C. CDC did an analysis to try to look to see how many more Scott counties do we have out there. And actually we were able to identify 220 counties that are vulnerable counties for where injection drug use could lead to substantial infectious disease outbreaks. And again, if you look at that pink area in the map, you can get a sense of what we showed about where we're having the opioid problem. You can see a lot of those areas are right in this area: West Virginia, Kentucky, Tennessee, and there are a number of very vulnerable communities that are basically only a blink away from repeating what the experience that we had in Scott County. But again, a number of these counties, we're trying to prepare them, in a sense, to recognize their vulnerability, to prepare them to enhance their prevention services, to work more effectively with partnerships with law enforcement and healthcare professionals, to work to try to engage more effectively in adherence to treatment, particularly for medical treatment for substance abuse, and begin to get a community-wide response proactively rather than reactive when these outbreaks occur. An example that I think is going to show us is going the wrong way is the interrelationship now between hepatitis C in our country related to drug overdoses. So here's at a time when we're, 3, 4, 5 years into curative therapy for hepatitis C, but we're actually seeing a substantial increase in the number of hepatitis C infected people in our country. About a 233% increase, some of the recent data that was presented to me, and again, directly linked to the realities of this ongoing opioid epidemic. If you just look at the maps, you can look at drug overdose deaths and new reported hepatitis C infections. You begin to see, I think, the geographic relationship. And it's clear that the hepatitis C epidemic is probably the one most notably that is going the wrong way as a consequence of the ongoing opioid epidemic in our country. A lot of barriers to getting and treating individuals effectively with hepatitis C, but I do think it's really important. I think one of the things that frustrates me now that I have the opportunity that I have is to see science on the shelf. I'm reminded about the fact that penicillin was discovered in 1927, and yet it sat on the shelf to the early 40s before people figured out that it really was important. I think here we have the scientific community has worked together in partnership with industry to accomplish something which many people thought was very difficult. When I was a young fellow and a young faculty or investigator at Walter Reed, I was supposed to be working on bloodborne non-A, non-B hepatitis, and everyone told me it was a career ender. But it's how I got sort of snuck in the back door to work on HIV, because I was working on bloodborne diseases. But look where we are today. You know, we basically have curative therapy, 6 to 12 months, many of which a number of you here have helped bring to reality. I know Henry's here, and yet that hasn't been applied to the population to the point that we've made an impact on the kinetics of the epidemic in our nation. As I mentioned, 233% increase in hepatitis C infections at a time we have curative therapy does suggest things are going in the wrong way. I'm very proud that Congress decided to give the 21st Century Cure Act great confidence that NIH will continue to provide scientific breakthroughs that will continue in the spirit of the individual this lecture is named for, to bring those scientific discoveries forward that can impact human disease. But I'm sort of an advocate now for the 21st century implementation of the Cure Act. When we have a cure like hepatitis C, we've got to figure out as a nation how to provide that cure, and we surely got to make sure that we don't lose the progress that we have because of comorbidities such as the drug use epidemic that we're confronting today. And so we'll continue to try to eliminate hepatitis C. Some groups have really made enormous progress. Clearly the Veterans Administration groups, Cherokee Indians have really launched a very good program. And there's a number of groups now that are launching campaigns to really go after the ability to put that science into action to eradicate hepatitis C. And again, I think we've learned a lot of lessons as we've begun to do this in how to basically develop the primary clinical settings to begin to prioritize that. Clearly, again, some of the work Henry and his team have done to try to get rid of one of the myths that you need some specialists to be able to be effective. I think if I remember your data correctly, Henry, even if the patient didn't show up after the initial randomization and just took the pills home, their cure rate was the same as if they went to the specialist. So again, we have the scientific tools to solve this problem. We just need to get them in the hands of the patients that need them. And the last comment I'll make about infectious disease interrelationships directly is the new outbreak that we've had across the country now for hepatitis A. A substantial outbreak, over 8,000 individuals now. This recently led to a change in our ACIP recommendations to basically do hepatitis B vaccination now to individuals that are homeless or use IV drugs, that we've clearly seen a fairly expansive outbreak associated with drug use and homelessness of hepatitis A across the United States. And this is the same as we would go back and look at West Virginia, which I talked about before. You can see that we've seen significant increase in hepatitis A cases in that group, but you've also seen substantial expansion of hepatitis C, hepatitis B in that population, a very tight interrelationship. The last area I wanted to talk about for a couple minutes is one that has been special to me throughout my professional career, and obviously Dr. Fauci also, and that's the AIDS epidemic. If you look at it, we really are beginning to make some progress in HIV infection. For many years, if we were to give this talk, we would talk about 50,000 new infections, 50,000 new infections, 50,000 new infections. You can see that between 2008 and 2015, there has been a decline in the new infections, but it's still 38,500 individuals newly diagnosed on an annual basis. That's substantial. And again, it's not incidence infection because this is not incidence data. This is just newly diagnosed in that year. Average time from probably infection to diagnosis has been estimated by some of our colleagues at CDC to be about 3 years. But it's about 38,500 individuals that we see. And if you look at the epidemic today, you can see that, as many of you know, it's disproportionately an epidemic in the South. And again, there's a number of reasons, and I'm sure Tony can talk more about it. But clearly, it's clear that we haven't been able to apply the scientific tools that have been made available to us for diagnosis, linkage to care, getting on antiretroviral therapy, assuring people are suppressed. And on the other side, people with behaviors that put themselves at risk to be able to modify their susceptibility by comprehensive prevention to include PrEP. Clearly, the South is being underrepresented in benefiting from those medical advancements. This is a map that Tony and I and others put together, and it's useful to me because many of us talked about the possibility of trying to end the AIDS epidemic in America. And yet it's really an aspirational goal. But when you look at the 38,000 infections last year and you map them out, this is a map showing you where 50% of those infections occurred. You begin to see that this is a fairly targeted situation that one can begin to try to develop the idea that different regions may want to begin to approach it. It's not something that we need to put maybe resources across every county, but there's some targeted areas. Very similar to what the PEPFAR program under Ambassador Birx has tried to do now, is make sure we're putting the resources where the problem is, as opposed to just dividing the resources by country. And this is a similar map if you go up to 72, 50, 32, 50, 75, and 90%. But you get a sense still that this is a very still targeted situation in the United States. This is one of the areas that I think is so important, and I know Tony's talked about it a lot, is the idea that, okay, fine, we know that we can get you in treatment and get you virally suppressed, and we do think there's scientific evidence to support that if you're virologically suppressed, that you're infectious, U equals U. On the other side of the coin, if you're still at risk, there's the opportunity to go on PrEP, which I think the data is just convincingly compelling that it actually works. This just shows you the estimate CDC did about where the people are that would benefit from PrEP. And then the map over here is a map similar to one that Tony showed recently at Emory, which is a map that sort of shows where the PrEP to need ratio is. And I think you begin to understand why the South may be disproportionately being represented by this epidemic, is that it is overrepresented in the lack of the ability to take advantage of the scientific knowledge that we've gained over the last 5, 6, 7, 8, 9 years, which is that we now have a biological mechanism to prevent HIV acquisition. It's called PrEP. But in order for it to work, it needs to be available and applied. This just looks briefly about the United States today. We still have a way to go as a nation. The data is a little out of date. I got this slide from my colleagues at CDC, and I told them they're making me feel like a medical historian again. I wanted something a little more updated, but they tell me the complexity is we don't get the reporting by the cascade for every state in the United States, and this is the last year they had every state in the United States, so they could give me the composited data. But if you look at, for example, the Ryan White program, we're doing much better in terms of viral suppression rates, almost 85% across the United States in the Ryan White program, which suggests that in patients that are in the clinics, that a majority of them are getting virally suppressed. If you look at the state of New York, you can see the state of New York is making sequential progress year after year after year in able to get significant viral suppression. And of course, in the program that you all started, Tony and Henry, in partnership with the DC Health Department, again, continuing to make significant progress in the District of Columbia to bring this cascade up so the individuals that are HIV infected know they're infected, they're in care, and they're virally suppressed. I bring this up because a lot of areas now are talking about beginning to develop their own regional efforts to try to eliminate the AIDS epidemic in their areas. Some of them, most notably, the effort that you all have done in the District of Columbia. I was shocked to see the change in new infections in the District of Columbia was reduced by almost 50%. New York, I've seen 4. Manhattan, Kings, Queens have reduced their new infections by over 25%. Again, suggestive that if you put the tools into action in these jurisdictions, that you can see the epidemic begin to decline. Finally, I thought I'd spend a second just talking about the priorities that I had at CDC and then open it up for questions. The priorities that I see for my own self is first and foremost responding to outbreaks, and the outbreak that I've put on top of the list for my time for as many months or years that I get to do the job is the opioid epidemic. And I say it for 2 reasons. One, I think it's the most serious public health crisis that's confronting this nation right now. And I also say it for a second reason, because it's very personal, and I've seen the pain that this epidemic has caused many, many lives. The second is disease elimination. We've talked a little bit about it. I think the hepatitis C is a great example. HIV is another one that I think has potential. Some of the jurisdictions are looking at it now. Obviously, one that's also really important to me is using immunizations to eliminate flu. You know, 80,000 people died last year from flu. Many of you may not know that over 10,000 of those people were between the age of 15 and 50. So it wasn't all just old people. And yet a majority of those people who died, they had one thing in common. They chose not to get vaccinated. Almost all the children weren't vaccinated. 47% of the American public gets vaccinated, right? And I have a goal to try to change that. You know, I don't understand why we don't put the tools that we have into action. Yes, I understand that the flu vaccine may not prevent everybody from getting flu, and some of it's messaging. When you hear that it only prevents less than 40% of people who get the flu vaccine are protected from infection. Well, that's one way to look at it. Another way to look at it is that how many of those people died? How many of those people went into an ICU? How many of those people were hospitalized? How many of those people got a clinical pneumonia that really put them on their backs for a while? The bottom line is the flu vaccine works really well in preventing the complications of flu. And again, we continue to work, and many of you are working on this, to improve the efficacy of the flu vaccine to prevent infection. But the bottom line, it's a highly effective vaccine in preventing the medical consequences. And it's very disappointing to see it sit on the shelf for so many families around this country. Finally, I talk about the priority of the global health security and domestic preparedness. I'm not going to go into details on that in this talk, but I think for me, this is the number issue that I focus on a daily basis, particularly the concerns of pandemic flu, the concerns of antimicrobial resistance, and obviously the concerns of outbreaks like the outbreak we have right now in the DRC. I close with just sort of a philosophical comment. Ed Tremont's seen this before, but I really think it goes back to the beginning of who this lecture is named after, of a quote that has always touched me when I was studying medicine, and I've kept with me since then. And really the center of all of this is bringing the power of science into action to improve the human condition. And it reads, "The preventive medicine dreams of a time when there would be no unnecessary suffering and no premature deaths, and when the welfare of people shall be our highest concern, when humanity and mercy will replace greed and selfishness, and it dreams that these things will be accomplished through the wisdom of man." And that's another code for the power of science. And finally, I sort of start where I started, where I remembered about our honored named lecture individual that I do think if you read some of the texts that I got to read about him, about sort of having that light bulb go off about, was it really possible that antitoxin was going to work? I'm reminded a lot of the things I may talk about when I talk about eliminating disease, for example, or getting flu vaccine rates up. I always try to tell people never underestimate the possible. And, you know, two examples I give. One is obviously what Tony was able to do with President Bush when a lot of people didn't think it was very feasible to put antiretroviral therapy in Africa, but obviously they did. The president put it out there and then led the nation to act, and you've seen the consequences that the PEPFAR is really probably one of the most successful public health interventions that we've done in modern times. But the other, of course, that's so notable is President Kennedy. And I remember well exactly where I was, just down the street on St. James de Chantal off Old Georgetown Road when he gave his Man on the Moon speech. I don't think President Kennedy, when he gave that speech, had all the science in his back pocket to get that man on the moon and get him back alive. But all I know is by inspiring the country to do that, that in 1969 we had one small step for man and one giant step for mankind. So my closing comment is that as we confront the AIDS epidemic, as we confront hepatitis C, and most importantly, as we confront the opioid epidemic, we have to understand to see the possible, use the power of science, and then lead the nation to act. Thank you very much.
Questions? Do we have time for questions and comments? Yes.
I was wondering, like, your thoughts or opinions on how the legal system affects addiction? For instance, for addicts who may have been incarcerated, how the repercussions of the legal system affect their ability to recover.
So the question was, what do I think about the legal system and what it may have, particularly on individuals' ability to recover, particularly if they get incarcerated. I think it's really important when we look at this as a comprehensive. My own son, for example, if it wasn't for the state of Maryland to recognize he had two choices, one, he could go through their system, or one, he could get into care and treatment. And if he got into care and treatment, they would support him going to care and treatment, and if he stayed, if you sense clean for a certain period of time, that they eventually would expunge his record. So I think it's very important to recognize this as a medical condition, all right, and to start confronting it as a medical condition. The second thing I'll say with that, and I've said this publicly, I do believe this, and this also goes to your question, the next important thing for young people or old people that have addiction and are recovering is they need to be able to get a job. Do you know how hard it is if you're a doctor and you've been found to abuse narcotics to get back, or a nurse, or a pharmacist, or a truck driver? It's very hard to get a job in any situation if they feel that you've been a successfully treated individual from or narcotic dependency. And I think this is a problem. This is why I've asked the Fortune 500 companies to join the public health community in helping us allow these young people to have the dignity of a job. So they need the dignity of not having a police record eventually. They're going to have to work for it. We need to have an enlightened judicial system that wants to give people the opportunity to get the medical treatment they need rather than read books by themselves in a jail cell. And then we need a public community that has the courage to hire these individuals. And I can tell you it's very hard today, right now. A lot of people have done what is considered almost the impossible. My son will tell you there's nothing harder than recovering from addiction. I'm joined him with it the day that he went into recovery, and Ed and others know I love a single malt scotch, but I gave up scotch. Haven't had a scotch since the day my son went in. I had one of the best scotch bars you could imagine, okay? I mean, I had probably $5,000 or more scotch, right? And I packed it up along with my friend Dave Pazza, and we went to the Veterans of Foreign Wars, and I handed over my scotch bar. And they cracked it out, opened it up, poured it with ice cubes, added water, and I almost had a heart attack. So I do think those are important things. The legal system is moving in this direction. They really are. Not in all states, but they need to. But we need the Fortune 500s. We need the people. We need people, even in this room, not to be afraid to hire somebody, to babysit or to do something. The jobs that someone like my son can get right now when he got out of recovery is he can be a barback carrying beer cases up to the bar. That's not the right job for him. He just fought to get out of alcohol. He just fought to get out of cocaine. Let the guy have the dignity of a job that his degree earned. And I said, there's so many people that are denied that dignity because someone feels, and I say this not because I mean it, but you can see how it sounds, because he's a drug addict. It's the wrong approach.
Dawei Lin from Date NIAD, and thanks for the powerful lecture. And I think I'm kind of inspired by you're showing the power of data, but also the power of availability of data in real time. And the CDC, I think in my mind, always kind of the historian aspect you kind of refer to. But given the advance of the computing technology and all other kind of sensors, do you think it's time to think about that the CDC can do some predictions before the crisis like the opioid happened?
Yeah, I think you hit it on the head. I mean, as the director of CDC, Tony and I were talking today about one of my priorities and core capabilities. Right now I'm sitting at CDC, I have 120 data systems that don't talk to each other. right? And now I just added in, I want every electronic medical record in every state, right? And that's exactly why we need to get a common interrelation data system that can go. Right now we've created it for opioids to monitor drug overdose. I think it's going to expand because the real purpose of data is to do just what you said. It's not to be historical. It's not to just tell everybody what it looks like today. It's to be predictive. And the only way you're going to be predictive if we have these huge data sets that are relational. And I think we will get to the point to be predictive. The map I showed you of the 220 counties is our first attempt to be predictive of the counties that we need to put more. And we now have, CDC now has what we call a rapid response team that now goes into those counties and are really looking for warning signs. Not after we just hear we had 233 cases of HIV, but right now that we know this county's at risk and we're putting these rapid deployment forces in to work with the state health departments to identify the vulnerabilities before we have the problem. So that's exactly how data needs to be used, predictively.
Thank you again for your presentation, Dr. Redford.
Don't I wish I was Robert
I wanted
Redford.
to ask about what...
He says he wishes he was Dr. Robert Redford.
It's all right. I like the Redford, actually. I'm going to start enjoying it.
I said, I hope you didn't hear that. When you spoke about the importance of addressing stigma in response to the opioid epidemic, a lot of my work coming in here today is in addressing HIV, particularly in the South. A couple of questions. One, what makes the part of the country, the West Virginias, the Appalachian Trail, so susceptible to the opioid epidemic, and how has places like the South, where stigma plays a huge role in the perpetuation of conditions like the HIV/AIDS epidemic, what's kept the South at bay as it relates to the opioid epidemic? And in your opinion, what are the roles of individuals and community-based organizations in supporting the CDC for making sure that the opioid epidemic doesn't become what it is now in other parts of the country?
Well, I'll start a little bit, and there's probably others that know more than I. I mean, clearly the West Virginia, Appalachian area, one of the biggest challenges there is, in my view, that opened up the door for opioids is the dignity of work. There is a huge amount of unemployment. So you have otherwise capable individuals that are forced to be idle, right? And I think that's contributed enormously negatively to the epidemic. And unfortunately, when that occurs, I think there's predatory individuals that see that as an opportunity. When it comes to the stigma in the AIDS epidemic, I don't want to tell anybody that I think it's over. We still have stigma, particularly for transgenders, that we need to confront in this country. We still have significant stigma in the South for men who have sex with men, particularly among religious communities. We still need to confront that. I think the way to do it is not to participate in being part of stigma. I will tell you, you have to be careful because there's a lot of subtle ways we all can be stigmatizing. And as you become more and more sensitive to it, you begin to see some of the subtle ways that maybe we've been stigmatizing. I would say, though, to your answer, I mean, clearly the opioid epidemic and drug use epidemic is still a problem in the South. You saw the maps, it's everywhere. But I would argue that probably the saving grace is that individuals have a dignity of some type of earning an income, more so they do in Appalachia. I mean, there really is. I mean, go spend a couple days walking through Appalachia and find out how many highly capable individuals just don't have a job. All right, and I think the dignity of work can't be underestimated.
So my question is, there are couple countries like France and Portugal that have had success with addressing this epidemic in their countries, and I know their systems are obviously different from ours, but their programs like increased access to MAT and to job placement, rehabilitation, harm reduction. Are you having the opportunity to look at other countries that have had success and to see where we could import some of those models and kind of build them into more of a comprehensive system for this country?
Yes, and even more so, I think this is the whole point of why President Trump and Secretary Azar have really made this pillars. If you look at the resources that are coming into SAMHSA now to expand access, I mean, I've told others that we have so much that we can learn from the AIDS epidemic. When the AIDS epidemic started, clearly we understood the stigma. But when the AIDS epidemic started to be confronted and be treated, we didn't have a health system that could take care of it. We didn't have a multidiscipline wraparound place where people could come in and get care from an HIV doctor, but also get care for their behavioral health service or addiction medicine, or by the way, they needed a social worker because they didn't have a place to live. We built that. It's called the Ryan White program largely. So I think you're going to see, what was it, Tony, $8.5 billion, if I remember correctly? There's a huge amount of new resources coming in for medical treatment. There are a number of pressure points now to try to get medical students graduated with the approval to be able to use buprenorphine. You know, a lot of times you'll see in some areas the number of prescribers that are approved to use buprenorphine way under the number that need it. So to try to improve the ability of medical treatment programs. One of the areas that I'll just tell you, having tried to navigate it for my own family, behavioral health medical services in this country are very tough. CDC just did an MMWR about 12 weeks ago on suicide. Many of you may have read it. Sadly, 45,000 people in this country committed suicide last year, 45,000. Some people said to me, but Bob, see, it's not all mental illness because 54% of the people who killed themselves didn't have any mental illness. I said, that's not the way I interpret the data. I think they didn't have access to mental services. All right, so I think we're looking at the others, and then harm reduction programs. You know, we do have a waiver program right now that there can be waivers granted for programs to help with safe syringe services. Again, we're going to take the position rather than have an opinion on some of these harm reductions. Again, let's let the evidence-based data speak whether they work or not work as they get studied in a systematic way. But I think you're going to see a long-awaited welcoming of expanded treatment services in this country as a consequence of the recent commitment.
Any other questions or comments? Yeah, Henry?
One of the points you just made was the difficulty of providers doing Suboxone or methadone. And obviously we went through an era where HIV was supposed to be restricted only to specialists, and then it's been opened up for testing, treatment to other people. We went through that with Hepatitis C. But now for providers, there are regulatory and practical issues why it's difficult for providers to give Suboxone or methadone and other things. In addition to medical students, are there other initiatives we need to do so that providers can co-localize services with whatever else they're doing and not feel that opioid use disorder or other substance use disorders are separate from what they're doing?
Henry, I couldn't agree with you more. I mean, one of the things, you know, right before I got the opportunity to go to CDC, I also was chairman of medicine at a sister hospital for the University of Maryland. And in that job, I had a division of addiction medicine. And in that job, I told my department that I didn't want the addiction medicine only to be practiced in psychiatry. I wanted it in the diabetes clinic. I wanted it in the hypertension clinic. I felt it was stigmatizing for someone that had a condition that required methadone or buprenorphine to feel the only way they could get it is they had to go over to a psychiatry clinic in the Carter Center. I thought, why not just let them get treated right with their diabetes center? So I think we have to expand it. There are some movement to expand it from the 30 to 100 to 300, the number. I don't know if there's been further discussions to deregulate, you know, further that in terms of what physicians need. I do know that a number of medical schools now are actually making sure when the individuals graduate from medical school, they're already buprenorphine certified. But I will tell you, as we stand here today, there's far fewer providers that are approved to use these important medical treatments than patients who need that treatment. So I do think we need to continue to expand how to make it so the barriers for being able to provide this treatment. I'd like to see it integrated into primary medical care. I'd like to see, addiction medicine be part of primary medical care. I think that's where it belongs. I think that in itself will be a destigmatizing event. That doesn't mean we can't still have specialists in addiction and psychiatry. No, I'm all for that. And there are some patients whose primary challenge is their behavioral issue. I mean, I'll argue, truthfully, back getting personal again, my son and his experience was that he didn't get the behavioral medicine care that he needed. He was self-medicating. He was self-medicating with alcohol, and he was self-medicating with cocaine. Cocaine, alcohol. I think a lot of the addiction use and the opioid addiction, the amphetamines addiction, the cocaine addiction, the alcohol that we have today are the people that have sort of been put in a corner to self-medicate because they haven't been able to be fully engaged in a behavioral medical system that gives them the behavioral medical care that could prevent their need to self-medicate. And I think the opiate, every crisis or challenge has a bright side. I think as we confront this opioid addiction, which we will, and you all will help solve it scientifically, I think we will create, just like we did with the AIDS epidemic, where we created a great health system with Ryan White, right, and the ability to wrap around, we will create a health system that begins to meet the behavioral needs of the American public. Because I think that's an area of medicine that just hasn't been developed.
Okay, last question.
Thank you, Dr. Redfield. I had a quick question. A lot of the presentation obviously was compelling and focused on prescription opioids. I'm wondering about sort of synthetic opioids and what the CDC, obviously it's can be more difficult to get statistics or get data on how those synthetic opioids are moving throughout the U.S. And obviously they're causing a lot of the more recent deaths that we're seeing, but what the current efforts are or what you're hoping to do.
Yeah, so most of what I showed you, it may got lost in some of the slides, is unfortunately the epidemic we're dealing with is synthetic opioid death. You saw that. One of the areas that CDC's tried to do is that we're beginning to move into most of the state and territorial labs now. We're moving in their ability to not just diagnose fentanyl, but to diagnose the derivatives of fentanyl, so that now we can get at the local level, they can understand to a better degree which of these derivatives are contributing in their area to the problem. As you know, unfortunately, there's much more potent sons and daughters of fentanyl now that are circulating throughout. So that's first and foremost what we're doing, is to try to be able to characterize both in overdoses and overdose deaths what is the polypharmacy. The other thing I should say, I didn't talk about it, but most of these individuals now are not single, they're not just a single product. So people will be using, synthetic opiate plus amphetamines, or synthetic opiate plus cocaine, or synthetic plus benzos. So we are putting in, and we're in the process over the last almost 4 or 5 months, putting in laboratory technology into the state and territorial labs so they can start to tell the difference between the different synthetic opioids. We are trying to facilitate the coroners, unfortunately, so they can actually get a timely diagnosis of the different agents that were associated with the overdose death. We're trying to make sure for the non-fatal overdoses that those individuals also are medically evaluated so we understand exactly what the agents are. So that's kind of where we're at, and to be at least able to be descriptive about what's there now. I will say, and I think you've pointed out, it is changing. So and what we were fighting 6 months ago is not what we're fighting today. So we are trying to make sure we have the laboratory technology so we know what's going on in the community.
Thank you, Bob.
Yep.